First of all, nobody calls me Dr. Barmada. That's my dad. I usually go by Sami. It's a lot easier. I'm a neurologist, and I work in the memory disorder clinic at the University of Michigan. But primarily, the majority of my time is spent doing research on Alzheimer's disease, but also many other conditions that may look a lot like Alzheimer's disease. And I'm very happy to be here today, largely through the invitation of a family member of one of my patients, whom I follow for one of these conditions that is not Alzheimer's disease. And I do want to say, following from that last speaker, this is going to be sort of an information-heavy talk. So I tried to pepper it up as much as I could to keep people awake. I'm the last speaker before lunch. Attention waivers, so feel free to interrupt me with any questions as the time goes on. All right, so I sort of call this talk when it's not Alzheimer's disease. Another way of thinking about this is that it's not always Alzheimer's disease. And I think there's a tendency to think of all dementia as being Alzheimer's. And I call this the Kleenex paradox, right? Because we all think of facial tissues as being Kleenexes, but really there's lots of brands of facial tissues out there, and many of them are softer. So Alzheimer's disease you can think of, so Dr. Giordani called this the umbrella phenomenon, right? Where dementia is the umbrella, and then there are all these different categories underneath. But what are these different things that may look like Alzheimer's? So when you take everybody who has memory problems, and actually probably a better term is cognitive problems, because memory is only one thing that your brain does. So when you think about the cognitive problems out there, about 60% are what we would classify as Alzheimer's disease. But there's a lot of other things that we now know about, and there's probably several that we don't know about, as I'll talk about later. So of this sort of group here, there's another 10% that we call vascular disease, and I'll spend some time going through these in more detail. But this is more like having sort of an accumulation of tiny little strokes that can affect your memory. And then there's this other category called Lewy body disease, which I think we're only, this is the numbers as of now, but they'll probably change because the more you look, the more you find these things. So about 12.5%. There's a really very heterogeneous or very difficult to recognize condition called frontotemporal dementia, about 7.5%. And then there's dementia with Parkinson's disease, which is a small sliver. And then there's this gray area, which is really other stuff that we don't have a name for just yet. All right, so Dr. Giordani spoke quite a bit on Alzheimer's disease, and so I won't touch on this very much. Just very quickly go through, because it's important to, I think about how other conditions could be different. So we know that Alzheimer's begins at some point, but it can be very hard to say exactly when it starts. It's gradual. Over time, things tend to get worse. And there's a lot of things that you can see in Alzheimer's. So it's not, we always think of it in terms of this forgetfulness, which, in the clinic we might call an amnestic disorder from amnesia. But there's a lot of things that you could see in Alzheimer's. So some people have predominantly behavior, their personality may change. They may get kind of aggressive or actually less aggressive. Some people have language problems. Sometimes people have a very hard time recognizing what's in front of their face. So for instance, you may say, please turn off the lights, and they'll be right in front of the light switch on the wall, and they're saying, I can't find the light switch. This may also contribute to when people say, I can't find my purse. Even though the purse is right there in front of them, they just can't recognize that object as a purse. And importantly, there's nothing else that can explain these problems. And so that really constitutes Alzheimer's disease in a nutshell. Under the microscope, just as we heard about before, you see these very characteristic things, these big globs here that we call plaques, and the black things that we call tangles. And so, again, I'm not going to spend a lot of time on this, but instead move on to these other things that can look like Alzheimer's. And I thought one way of doing this would be to talk about people. And these are real people. This is not their real name. But these are people that we have seen in the clinic. And so this person, Carl, says, I'm okay. I feel fine. normal 78-year-old. But his son says he just hasn't been the same since he had a heart attack the last summer. And his son is really worried that some of this could be due to his heart attack. And so what we're getting at here, I'm going to cut to the chase, is that Carl has something that we call vascular dementia. And vascular is just this word that refers to blood vessels. And when you think about cholesterol, when you think about high blood pressure, you think about those little tiny blood vessels that go to your heart, and when they get blocked up, you get a heart attack. It turns out that you also have a ton of blood vessels that go to your brain, and they are affected by exactly the same things that affect your heart. So this is as we saw, this is probably the second most common form of dementia. And it's also very hard to pick up because it can come up very gradually or it can happen very suddenly, as you would expect for a stroke. It's about 10 to 40%, so incidence varies, and it turns out there's no hard numbers because even though we as human beings like to say, this is Alzheimer's and this is vascular, the reality is nothing is pure, right? We live for a long time, and stuff happens to your brain. And not just one thing happens, but everything happens. So, but in general, vascular disease is present in almost everybody. It's just a matter of how much. And there's a lot of overlap with Alzheimer's. So we hear this term a lot, executive dysfunction. This is something that you will certainly see in Alzheimer's and in vascular dementia. And I think of this as all the sort of higher cognitive functions that we think of with people, right? Mathematics, planning, multitasking, prioritization, all these things that are really hard to describe. It's not necessarily memory, like I can remember that list of 14 words. It's what do you actually do with those words. All right, so this is really closely related to stroke, as I mentioned. One of the primary ways in which we can recognize this condition is through head imaging, so taking a picture of your brain. CAT scans are fine, but MRIs are a little bit better. This is kind of what it looks like. All right, so in general, the nice thing about MRI, well, it's really complicated, but the nice thing about it is that in certain ways, the bright things are the bad things, right? So you shouldn't see a lot of these white spots here. And each one of these white spots is a tiny, tiny little stroke. That means the little blood vessel that goes to that part of the brain got clogged up. And the part of the brain that usually gets blood didn't get it, and it died, and it turned white on the MRI. The really amazing thing about your brain is that this can happen without you knowing it. And that's because there's all this other healthy brain, this gray stuff. And when a tiny little stroke happens, you get the area right next door that just picks up the slack. And your brain just does that automatically. It rewires, something that we call plasticity. And so you can go on, have hundreds or thousands of these tiny little strokes and not know it until you run out of the neighborhood, right? You don't have any more healthy brain to pick up the slack, and then you start feeling it. And that's what typically shows up as a memory problem. So this is the sort of gradually progressive kind of condition. But as I said, sometimes you get the vascular dementia from very sudden onset. And so this is what a big stroke looks like on an MRI, is one big bright spot, right? And so this is how we can often tell these things apart based on MRI. But clearly, while you can feel absolutely fine with this, if this happens all of a sudden, you're going to have very significant problems that are going to show up in other ways. All right, so what are the risk factors? Kind of talked about this a little bit before, but age, as we get older, those blood vessels get a little bit more brittle. Unfortunately, being a guy sometimes is not a great thing. Family history, so if people in your family have had strokes, you're more likely to have strokes. High blood pressure, high cholesterol, diabetes. If you've had a stroke, you're more likely to have a stroke. And then, of course, cigarette smoking, which as with heart disease, it affects all your blood vessels. Okay, so what do we do if somebody has vascular dementia? Is there anything that we can do to treat this? Well, the key is to keep it from getting worse. So even though your brain is this amazing organ that can really cope with all these damages, you can't really regrow parts of your brain. It's not like your liver. Working on that, but as of now, we can't really do that. So What you do, you try to address those risk factors, treat the blood pressure, treat the diabetes, lower the cholesterol. You'll get a lot of these blood thinners like aspirin that help that blood go through those blood vessels that are being squeezed shut. Sometimes, if it's really bad or if you have an abnormal heart rhythm, you'll get these very strong blood thinners like Coumadin, or now Eliquis, which is really nice because you don't have to get your blood drawn every now and then. Sometimes, if there's a plaque, you can get that removed. Of course, stop smoking. This is a really big one that I don't emphasize nearly enough. So we'll come see this again and again. But of all these conditions, Alzheimer's, Lewy body, vascular dementia, there are medications. And to some degree, the medications work. In my opinion, they don't work nearly well enough. As important, or even more important than the medications, though, are what you do. So your lifestyle. So healthy, regular amounts of physical activity, keeping sort of limber with your mind, kind of the theory of use it or lose it, right? It does not just apply to your body, it applies to your brain. And that is just as important or more so than these medications. And then sleep. Sleep is incredibly important. You can ask any medical resident out there, if you don't sleep, you're dumb. And it continues over time, and it's cumulative. So we don't pay enough attention to sleep. Okay. So I'm going to switch gears now to another person, Charles. And this is a little bit more complicated. So he's having problems concentrating and doing his work. He's actually passed out a couple times. He sees kids in their yard, although nobody else seems to see these kids. His wife complains that he gets almost violent at night sometimes, and so much so that she has to sleep in another room. As a matter of fact, he's had problems for many years, including sleepwalking, and he has a mild tremor of his right hand. Anybody want to take a guess? Yes? Ding, ding. All right, so let's talk a little bit about Lewy bodies. And you'll hear these terms used interchangeably. So dementia with Parkinsonism, Lewy body disease, and Parkinson's dementia. So what is the deal with this? So Lewy body dementia is a condition in which the memory or the cognitive problems come first. They precede any signs of tremor or stiffness or falls or slow movements that you might see in Parkinson's disease. All right? In Parkinson's dementia, the Parkinson's-like symptoms start first. So you have that tremor first, and then you have the memory problems. Underneath the hood in your brain, it's the same thing. And yet clinically, we call them two separate things. They're treated identically. So this is about 15 to 20% of people who have memory problems. And under the microscope, like I said, they're the same thing, and they have these things called Lewy bodies. We don't, unlike the previous speaker, the pathologist didn't ask somebody to say, hey, you see this body, would you like to give it a name? And they called it Louis. It's actually named after a pathologist named Louis. His last name was Louis. And this is what we see. It's very characteristic. So what is Lewy body? We talked a little bit about this. The essential features are this executive functioning that I told you before, very prominent, so much so that people have a really hard time following directions. If you try to tell them more than one thing at a time to do, they cannot put those things in order. There are these other features that are much more characteristic. So for everybody, there are good days and bad days. But for people with Lewy body, it's really like sometimes they can't even move or get up out of bed versus kind of being the same person that we're all familiar with. There are very characteristic hallucinations. And these, we'll talk a little bit more about them. There are some sleep problems that we'll talk about some more. And of course, these things that you see in Parkinson's a lot, including the tremor, problems walking, and feeling very stiff. So let's talk a little bit about these hallucinations. So they're usually people that come from that person's experience, or they're animals, dogs or cats that they've had in the past. I've had people say, I'm looking out my window and I see a band playing, And then you can ask about it. Well, what are they playing? They're playing bluegrass music. I really like the music. And it turns out they have a connection with bluegrass in the past. They're almost never are they troublesome. They're not scared or worried by them, although they can be. But they're generally friendly. And not always, if somebody has a friendly hallucination of a person that they haven't seen in a long time, is that worth, do we treat that? Do you give them a medication to eliminate that thing that is not there but is not troubling them? I don't always think so. So that helps us recognize Lewy body. This other thing is this condition called REM sleep behavior disorder. And this is what I was referring to before about the wife and the fact that her husband was kind of getting a little aggressive and punching her. REM is rapid eye movement. That's that deep stage of sleep when only your eyes are moving. Only your eyes are moving because there's a really critical part of your brain that cuts off all the impulses from your brain to the rest of your body, except your eyes. So you can dream. So you can think you're moving around, and yet you're not moving around. What happens in this disorder is that sort of gateway to the rest of the body does not work. And so you are dreaming, you are killing that snake, but it's not actually a snake, it's your partner in bed. And by the way, this is sometimes what happens with Ambien. This medication used to be used a lot to help people sleep. And then there were these reports of people getting up and driving or doing something with their partner. And that's the problem with Ambien, is that it sometimes results in similar behavior. Okay, so that REM sleep behavior disorder can show up 5 to 10 years before somebody develops Lewy body, and it's very characteristic. So other things, sometimes people are very sensitive to drugs, and in particular classes of drugs that are meant to relieve hallucinations. And sometimes there's falls. There's almost always these symptoms like constipation, incontinence. This is a problem with a part of your nervous system that we call the autonomic system. MRI scans are not very useful. Neither are CAT scans. Some more specialized form of imaging, including PET, is potentially useful. And I'll talk more about that later. And then even better, though, however, are these other kind of tests that we can run if we're worried about or concerned about Lewy body and we want to confirm that. So the DAT scan, I'll talk very briefly about, but it's not typically done in the United States, very often done in Europe. It's very sensitive. So if anybody has Lewy body, you'll probably detect them using this scan. Right now, it's typically done on a research basis, however. There's another study called MIBG, myocardial scintigraphy, which again, we don't use very much in the United States, more often used in Europe. And it looks at your heart and the nerves that go to your heart. And so you can see here, there's a lot more dark stuff than there is here. But there's less right here. And that's the part that you look at. This is exactly why we don't use it very often in the States. It's difficult to interpret. Better, though, is this. So if you're worried that somebody has Lewy body and you think there's some problem in sleep, even if there's not a problem with sleep, you can get them. You can request a sleep study. And so what happens in a sleep study, some people have probably had these sleep studies. You go into like a hotel or someplace that looks like a hotel, and they hook up all these wires to your head, and they tell you, please go to sleep, even though it's nearly impossible to sleep. And then they look at what happens, the electrical activity that they can measure from your brain. But they also have leads in your muscles, and they have leads on your eyes. And so they can tell when you're in REM sleep. So this is called REM sleep without atonia, and it can also be very helpful. Okay, so what else do we know about Lewy body? If you, like Bruno mentioned, if you get 23andMe and you get this Excel spreadsheet with a bunch of genes, these are the ones that may pop up. This one is a gene that encodes for that protein that is in the Lewy body. This is a very interesting gene that's associated with a different type of disorder called Gaucher's. And then ApoE, interestingly, is the major gene risk factor for Alzheimer's disease. but in this case, it can also be responsible for Lewy body. So great, you can make the diagnosis, but what do you do for a person who has Lewy body? So it turns out that there are these medications that Bruno mentioned before that are often used for the treatment of Alzheimer's disease. Strangely enough, they have often a more pronounced effect in people with Lewy body than they do in Alzheimer's. So prescribe these with somebody with Alzheimer's and they say, I don't really feel anything. And in my opinion, I say, that's great, you're not having side effects because it's really meant to keep things from getting worse. But in Lewy body, often people will say, I just feel like I'm more able to do things. And family members might say, I can't put my finger on it, but they're more like they were before. And that's because they improve this category that we call executive functioning that is hard to define in the first place. But that improvement can be a sign that Lewy body is present. So there are these hallucinations that occur, and often they're not worth treating at all, except when they interfere, right? So if somebody does become very paranoid or scared, or they're not really enjoying it, then you can treat them. And the same medications, these cholinesterase inhibitors like donepezil or Aricept, can really prevent those hallucinations. But there are other medications, including this new one, that can be effective in this case. REM sleep behavior disorder, definitely worth treating if somebody's getting into trouble, hurting themselves or hurting other people. This melatonin is a very safe medication that's available over the counter and can be effective in REM sleep behavior disorder. Anybody who takes melatonin, you have to stay away from light. I don't know if this is on the product label or not, but fluorescent lights, sunlight, that breaks down melatonin. This is part of your body's natural cycle. So melatonin is something your body makes. In the good old days when we didn't have fluorescent lamps, your body makes melatonin, but you're out in the sun and it breaks it down. The sun goes down, you continue to make melatonin and it builds up and you start to feel sleepy and you go to bed. And then when the sun comes up, it hits you and you break down the melatonin and you wake up. And so that's why we prescribe melatonin, because it's the thing that makes you sleepy. And then there are these very difficult to treat things that make you fall, autonomic symptoms. So the incontinence, the constipation, the falls. There's a lot of methods for addressing these. I tend to prefer the ones that don't involve medication. So if you're passing out a lot, falling down, something as simple as using compression stockings can really help return that blood flow to your heart and keep you from falling. But there are means of addressing this otherwise. And then for some of the Parkinsonism, there's physical therapy, like directed physical therapy for Parkinson's, but also movement classes like Tai Chi and boxing that really help people with these big movements. And then more traditional therapy with cinnamon. All right, so that's actually what we currently use, but there's a lot of things right now that are being tested for Lewy body, and I'm not going to talk in detail about many of these. I think the point of this is just to say current therapies are incomplete. I'm going to switch gears again. So this is Connie. She's 66, so quite a bit younger than these other people, and she's getting confused. She's having problems driving. She's quiet. May not always understand what you say. And now she started eating donuts and put on a lot of weight. She's never really done that before. Real sweet tooth. Anybody want to take a guess? We're running out of options on that list. All right. Yes, this is frontotemporal dementia. And part of the reason why this condition can be very hard to recognize, A, it occurs more often in people who are younger, and B, it does not look like a dementia. At least our sort of social construct of dementia is somebody who is forgetting things. Frontotemporal dementia, people start behaving very strangely. In frontotemporal dementia, you may have these personality or behavioral changes. And so actually the most common one, too, are apathy and lack of empathy, right? So that's a lot of pathy. So one partner will say, they just don't care about me anymore. Like there's no there's no feeling or emotion. And apathy is really related to that. It's kind of like they have no motivation, right? All they want to do is sit. If you tell them what to do, they may do it, but they're not going to get up and do something themselves. That can be really hard to recognize. As a matter of fact, most of the time, people think they have depression or they have some sort of psychiatric disorder. There's a lot of social withdrawal. There's sometimes eating disorders, as we mentioned. And you can think of this as kind of, we all have impulses. And generally speaking, we check those impulses. But people with frontotemporal dementia may be unable to check those impulses. So this results in inappropriate comments to people, typically things you wouldn't say out loud. Or if you see something sitting there on the table, you might just eat it because you feel like it. A lot of poor judgment. There's also quite a bit of language problems, so this sort of runs the gamut. And then you have these other things that can look a lot like Parkinson's, can look a lot like ALS, or also known as Lou Gehrig's disease. This is the thing that got the Ice Bucket Challenge a few years ago. So right here you can see why it's so hard to recognize frontotemporal dementia, because it can really be so many different things. And as a matter of fact, this is a sort of broken down categorization. About 4 out of 10 people have those behavioral problems. About 4 out of 10 have language problems, and the remaining have these motor problems. So it really hard to classify, hard to detect, and definitely not something that a primary care physician is going to be able to do within that 8-minute span of time that they have to talk to you. So what would you, if you did an MRI, what might you find? One of the reasons I like frontotemporal, I appreciate frontotemporal dementia is there's not a name attached to it, like Alzheimer's or Lewy body, right? I think you know right off the bat that it involves the front and the temporal sides of the brain. And you can see that on the MRI. So this is the front part of the brain on the MRI. So this is your nose, this is your back. All of MRIs, they're slices. They're kind of slices through your brain, and this is a slice going this way. And you can see that the brain has really shrunk in the front. This is a different kind of slice that's going this way. So this is the front of your head. This is the back of your head. Radiologists really enjoy confusing people. So this is your right, and this is your left. And you can see that this is around the temples, and you can see there's some shrinkage going on there. And this is the last slice that is going up and down. And you can see, again, shrinkage on the top of the brain. So these are the ears, the neck, and the top of the head. You can see some shrinkage on the top. So this is something we call atrophy. And in this very blatant example, you can see that it's more pronounced in the front and the sides, or the temporal regions. So MRI is helpful, but it's not always very helpful. And so there are several things that you can do beyond MRI, some of which are available and utilized. So Bruno alluded to this. This is something called FDG PET, or more often just called a PET scan. And it takes advantage of the fact that your brain likes sugar. So your brain operates on glucose. And so what happens in this PET scan is they use a version of glucose that you can see on a CAT scan. And so you give somebody this, you inject it through the IV, your brain uses a lot of it, and we can see how much each part of the brain uses based on the signal from the CAT scan. So it's a way of telling how active your brain is. It's actually very useful for distinguishing frontotemporal dementia from other things like Alzheimer's disease. And even though the FDA approved it, Medicare approved it, Blue Cross Blue Shield decided 3 years ago that we're not going to fund any of these things ever for diagnosing dementia. And so the out-of-pocket costs are around $5,000, typically not something that we would recommend that somebody does, unless absolutely needed. This is what it looks like. So if your brain uses a lot of sugar, it shows up dark. In those regions that don't use a lot, it shows up light. And you can see here that there's less in the front. And if you use fancy software, you can make those areas really pop out in purple. So beyond this PET scan, if it's not something that we can recommend and insurance is going to pay for, what else can we do? So it turns out that previously, I think, in particular for Alzheimer's disease, there is no test that you can run a blood test or you can run some other test and say you have Alzheimer's. It's always based on sort of clinical impression. But now, actually, there are tests. This is one that we do not infrequently. As of now, it still requires spinal fluid. So we don't, it's not something I would recommend that everybody does. But if there's a reason for it, you can obtain spinal fluid through a spinal tap or a lumbar puncture. It's not as big of a procedure as many people would think. And it can be remarkably helpful. You can pick up almost 100% of people who have Alzheimer's and rule out other conditions, again, in a large number of people. And you get this very helpful, this is what happens when you get these results back. You get this plot here that says, if you fall in this quadrant, it'll plot a couple things that you get. It'll say, this is really strongly associated with Alzheimer's disease. And if you get this value up here, it says, well, this is probably not Alzheimer's. The difficulty comes when you get something in these two quadrants, and then the test says, I don't know what's going on. So, but that doesn't happen as often as long as we recommend the right people. So for frontotemporal dementia, is there a test? The answer right now is no, but I think probably within the next couple of years, that's going to change. So it turns out there's a protein called neurofilament light, which is conveniently abbreviated as NFL. And for people who follow the story with head injury and NFL players and frontotemporal dementia, it's really easy to remember. So you can measure this protein in the spinal fluid, and it's higher in people with frontotemporal dementia. And it turns out it's not just spinal fluid. So you can measure this in blood as well, and you can get very similar data. So it's very possible that this test will be available soon. It's not entirely, everybody who has a high NFL level is not going to have FTD. There are other conditions like Alzheimer's or ALS, for instance, that will give you something like this too. But in the right person, you can use it to help diagnose the condition. Okay, and it turns out that not only can you use it to help diagnose, but the number that you get may be very helpful. So let me kind of walk through this. So let's just focus on this side. So if you measure somebody and they have very high neurofilament levels, they may develop disease or progress much faster than people who have low neurofilament levels. So not only can this help in diagnosing, but it can help in telling somebody what to expect in the future. Okay. So there are other very fancy things that are typically research-based right now that I would really hope would become more available soon. Bruno talked about this. This is a way of picking up Alzheimer's disease in the brain through imaging. Now, we don't necessarily have to be able to look at that brain under the microscope. We can use PET scans. It's clinically available. We can write a request for this, but insurance companies don't cover it. And there's something else that looks at that other protein in Alzheimer's, and it also builds up in frontotemporal dementia, but it's only research-based right now. So again, I talk about this because I do believe that this will change soon, as people realize how effective these can be in diagnosing the condition. It's also raised a number of really interesting questions. So this is the amyloid PET scan. And somebody with Alzheimer's disease, these are different slices of the brain, and the warmer colors show you more of that amyloid protein building up. And so you see a lot of it in Alzheimer's, and in most people who are normal, you see very little. It turns out, though, if you just take 10 people off the street and give them this amyloid scan, most 8 out of 10 will look like this, but 2 out of 10 have a ton of that amyloid protein in their brain. And this was not expected when people first started doing this. And they said, well, what's up with that? And it turns out if you follow these people over time, they have a substantially higher risk for developing mild cognitive impairment and Alzheimer's disease down the road. So this raises the question, it's kind of a hairy question, but should this be offered to people, say, beginning in their 40s to determine if you're at risk for Alzheimer's disease? Right now, most people would argue that no, you don't need to do that because there's nothing we can offer that person in their 40s to say, take this and you'll be fine. We can always recommend those lifestyle modifications that I mentioned before that are remarkably effective. I think everybody should be doing those. But without some sort of directed treatment, nobody's going to pay for that. So back up and again, thinking about Bruno's talk, some of these therapies that are being tested right now, the ones with the really memorable names like aducanumab or solanezumab, they did not show very much improvement in people who already had Alzheimer's disease. And so the thought was, well, we need to give them to people before they develop Alzheimer's disease. And so those are the trials that are going on right now. Now, let's just say for argument's sake, say those trials turn out to be positive, and saying if you get some of that therapy starting in your 40s and it can prevent Alzheimer's disease, that's really remarkable, right? That's our first effective treatment. But now factor in the cost that these are antibody-based therapies, so they're biologicals. You have to get an IV infusion every month. The estimated cost is $100,000 per year. You start that in your 40s, and the number of people at risk for Alzheimer's disease is pretty much everybody. That is a cash cow for the drug companies, but what's it going to do to us, right? Who's going to be able to afford that? The major burden, developing burden for Alzheimer's disease, of course in the United States it's very high, but it's actually in sub-Saharan Africa and developing nations because their population is living much longer, and so many more people are at risk for Alzheimer's. Do you think, are they going to be able to pay for it? Who's going to have access to this? I don't know the answer, but I think it's going to involve the 1% or the 0.1%. We're going to talk about tau. That's okay. It's another one of these PET scans that is expensive. So as opposed to Alzheimer's disease, so people with Alzheimer's disease, only 1 out of 10 have a true family history. I mean, when I talk about true family history, I think nearly everybody can say that at least one person in their family has Alzheimer's disease, right? But when we say family history, we mean somebody with the development of the disorder before the age of 65, because that's where genes play a really strong part. In frontotemporal dementia, that's much higher. So 4 out of 10 people will have some sort of gene that you can find on something like 23andMe that is associated with the condition. And really, there's 3 major genes that you can find. So it's a simpler, although perhaps more impactful calculation. And then a lot of times people don't just, this is what complicates it, the genes that cause frontotemporal dementia, they also cause ALS. And so you'll see these families in which somebody will have frontotemporal dementia and somebody will have ALS, and really you got to consider them to be the same condition. All right, so what do we do? Somebody is diagnosed with frontotemporal dementia, so we tend to treat the symptoms. Right? So if somebody's depressed, if somebody has anxiety, somebody has psychoses, then we use a lot of the medications that are available to treat those conditions. And they fall into these camps like SSRIs or SNRIs that are very often used to treat depression and anxiety. Psychoses, a lot of behavioral modifications can be very helpful. So prior to using medications to just redirect somebody, sometimes just being around family members, hearing the voice of a family member can be very helpful. But in some cases, when medications are used, they can also be helpful as well. Language problems, very hard to treat. Speech therapy can help. There are directed speech therapy programs in which people can make a remarkable amount of progress. But as soon as they stop doing that therapy, then they tend to regress. Cognitive problems, really there's nothing that we have available to help with this. Nothing as of now. And then if there's motor symptoms or Parkinsonism, then again, we sort of fall back on those things that we use to treat Parkinsonism. So you'll notice that really with frontotemporal dementia, there is no directed treatment. We sort of borrow from all these other conditions to sort of treat the symptoms, but nothing directed at FTD itself. So there's a lot of stuff in development right now, which is very exciting, I think. I've highlighted a couple, but I'm just going to spend 30 seconds talking about these things called ASOs. So this, I am hoping, will be the next very exciting thing for neurologic disorders, including dementia. So there is a lethal condition among kids called spinal muscular atrophy, or spinal muscular atrophy. And these kids, we call them floppy babies. So when they're delivered, they have so little muscle tone in severe cases that they just flop down on the bed and they can't move. And when the disease affects the muscles that they use to breathe, these children die, right? And it's lethal, something we've known about for a while. There's a lot of science in there, and now we have this treatment. It's called nusinersen. It's a medication that you have to give directly into the spinal fluid. These babies not only are they not dying, they are now regaining their strength and walking. It's incredible. It's probably the first case in which, in neurology at least, we've been able to make that much of a difference. It's not perfect. They're not normal by any means, but they are living and attaining their developmental standards. That same technology is being used for dementias, including Alzheimer's disease. There's a trial on Huntington's disease that just saw some pretty significant effects. There are ongoing trials for Alzheimer's and frontotemporal dementia and a bunch of other conditions too. This is a huge wave in therapeutics right now that many of us are very excited about. Okay, and there's a lot of other things to be excited about. The list goes on, and I won't spend any additional problems. So I do want to just end with this. This is what we talked about before, the Kleenex paradox. Now, to make things even worse, as Bruno mentioned, we're going back to look again at Alzheimer's. It turns out not everybody who we've said has Alzheimer's actually has, under the microscope, Alzheimer's. And I will just, before clouding the waters any further, this is a condition that we call late. It's named very well because it shows up more often in people as they age. So if you look at people in these much older age ranges that we've never studied before, only within the past few years, the people with Alzheimer's actually plateaus as you get into your hundreds, right? Something to look forward to. But you're welcome, because we're all going to get there. But the people with this condition, this late, actually continues to go up. And it has this wonderful, it's an acronym that stands for this condition called limbic predominant age-related TDP-43 encephalopathy, which is why we call it late. And we don't know what this is. We don't know how to recognize it. We don't know how to treat it. But that's what we do in the lab.